Hello, my name is Arif Khwaja. I'm a nephrologist at the Sheffield Kidney Institute, and what I'm going to do in the next 20 minutes or so is to give you a brief overview of the importance of BK nephropathy in kidney transplantation. So what are we going to talk about? Background and epidemiology of BK nephropathy, pathogenesis and what the clinical manifestations are. We'll briefly review risk factors, talk about how we can make diagnosis, and then talk about management, which really corners around preemptive surveillance and treatment. So, what's a little bit of background about the virus? BK is a polyoma virus. It's a double-stranded DNA virus with 5,100 base pairs, and it's got 2 regulatory proteins and 3 structural proteins. There's no antiviral target such as a polymerase or protease, which obviously makes it difficult to develop new treatments, and it shares 75% of its genome with JC virus, and it was named after a Sudanese patient who I think was in St Mary's Hospital in London in the early 1970s, who developed ureteric stenosis after kidney transplantation. So a little bit about the virus itself. So it often causes primary infection in the first decade of life, and it's usually asymptomatic. It's common, so roughly 82% of people have IgG seroprevalence if you screen a bank of healthy blood donors. And basically what happens to the virus is that it just latently colonizes the urinary tract as a result of the primary viuria. And in fact, if you look at healthy blood donors, again, 7% of those healthy blood donors will have viuria. 10% of immunocompetent hosts can have BK viuria without any viraemia. Up to 25% of kidney transplants may develop BK viuria, and that may progress to viraemia and then to BK nephropathy or Polyoma virus-associated nephropathy in around 10% of patients. For the purpose of this talk, I'm going to call BK, when I refer to BK nephropathy, I'm really talking about, I'm using the words PVAN or Polyoma virus-associated nephropathy interchangeably. So the polyoma virus is in human disease, so you've got BK virus that can cause PVAN, polyoma virus-associated nephropathy in kidney transplantation. In bone marrow transplantation, you tend to see hemorrhagic cystitis. And JC virus, much less common, but can cause a progressive multifocal leukoencephalopathy, and in renal transplantation may also cause a polyoma virus-associated nephropathy type picture. And SV40, the hosts are sort of non-human primates really, and so the significance of SV40 viruses in kidney transplantation not so clear. And why does it matter? Well, BK virus adversely affects graft outcomes. So if we look at this data, which is from the STRT, which is Scientific Registry of Renal Transplants, a database in the States. This looks at a large number of patients who had a kidney transplant between 2004 and 2006, so just under 43,000 patients. And they looked at the coding for those patients, and those who were coded as having treatment for BK were identified. And what you can see is that if you have BK, the graft survival is poorer, patient survival probably not so different, but death-sensitive graft survival again is poorer. Okay, and they identified certain key risk factors for BK nephropathy, including age, male sex, African American race, donor age, and HLA mismatch, and the use of immunosuppressants such as tacrolimus and thymoglobulin. Okay, so let's just talk a little bit about the pathogenesis and clinical manifestations of BK nephropathy. So you have the virus that's sitting latently in the renal tubules. With the administration of immunosuppression, you get reactivation of the virus, effectively causing tubular cell infection and damage, leading to cell lysis, and that will cause viuria. As you get denudement of the tubular basement membrane, you can get spread of the virus into the bloodstream, and therefore you'll see vascular BK viremia. Quite often you'll see interstitial inflammation and tubulitis, and very difficult to differentiate from rejection sometimes, so you may see that. And you will have what's been noted is that viral replication is initiated in the non-coding control region, and if you have NCCR rearrangements, that's associated with higher levels of BK viremia. Humoral immunity only provides partial protection for BK nephropathy, so BK virus clearance is associated with the emergence of virus-specific IgG antibodies, but adaptive immunity is also important, and so BK virus-specific T cells are associated with sort of clearance of the virus. So if you like, there is a specific cellular immunity element to the clearance of the virus. So this is a rather busy slide, and I'm afraid it's a bit, the legends may not be very clear to see, but basically what this data is showing is if you take, this is again data from I think the Austrian group, if you take patient A who is diagnosed, and on the bottom axis you've got diagnosis after BK nephropathy, after BK virus associated nephropathy, you'll see you have BK viremia, which resolves relatively early after immunosuppression reduction, so the MOF is switched to azathioprine, and the tacrolimus is switched to cyclosporine, and here you have resolution of viremia. And associated with the resolution of viremia, you have development of BK-specific antibody and BKV-specific T cells. Okay, that's in the top panel there. So viremia, as the viremia clears, you develop antibodies, and you develop BKV-specific T cells. So those with, if you like, the self-limiting disease develop these BKV-specific T cells quite early and clear the virus quickly. Patient B, his immunosuppression, although immunosuppression is maintained, BK virus is reactivated in blood and protein, in the blood and urine, but you get much later development of the BKV specific T cells, so these tend to occur much later. Okay. So what does all that mean? Well, I think it basically means that you have BK specific T cells that target viral proteins, and the development of BK specific T cells are really what determine the resolution or progression of BK disease, of BK nephropathy, if you like. So you have kidney with latent beta V infection, have a number of risk factors. You get amplification of the virus as a result of immunosuppression, and eventually develop an antibody. If you develop specific T cells, then you can develop a kind of cytotoxic reaction, cytotoxic lymphocytes that target those viruses and promote viral clearance. So what are the risk factors for BK nephropathy? Well, the patient-related ones are age over 50, male, diabetes, and negative BK serostatus before transplantation. High degree of HLA mismatching, rejection episodes, renal injury, and latent infection load. And then there are factors related to the virus, such as the genotype and the number of non-coding region rearrangements. Sorry, non-coding codon rearrangements. So what are the clinical manifestations? Well, the clinical manifestations of BK nephropathy are usually an elevation in serum creatinine, so a decline in gland function. So polyoma virus-associated nephropathy can affect up to 10% of patients. You can also get urethral stenosis. You can get hemorrhagic cystitis, usually seen in bone marrow transplantation. And there are associations with cancer, with urothelial cancer. So BK viruses can drive malignant transformation within the cells. Usually manifests in the first year, but maybe later. And as I said, it's characterised by this progressive decline in kidney function, and it's confirmed by biopsy. And if you look at the evolution of polyoma virus-associated nephropathy or BK-associated nephropathy, first of all you see BK viuria here in the black squares, and then you see increasing levels of viraemia in the sort of triangle here, and then as the viremia increases, you get a rise in the serum creatinine here, relatively late, sort of later after the onset of viremia, and then when you have significant rise in creatinine, obviously that indicates that you have established polyoma virus-associated nephropathy. Okay, so viuria followed by viremia, followed by organ dysfunction and histological change. So this slide summarises the kind of 3 different histological classifications of BK-associated nephropathy, and you have the University of Maryland classification, the AST classification, and the Banff working proposal classification. All slightly different, but in broad terms quite similar, really. So you have 3 patterns of it, 3 stages of injury: A, B, and C, or 1, 2, and 3, with increasing severity. And in stage A, or pattern A, you'll have really very minimal effect of the virus. So you might see a little bit of cytopathic change on the biopsy, but otherwise the biopsy may more or less appear normal, with negligible inflammation affecting probably less than 10% of the biopsy. In stage 2, you'll have much more significant inflammation, and you'll have evidence of cytopathic change with inclusion bodies, and that will affect significantly much more than 10% of the kidney biopsies, at least up to 50, and may affect up to 50% of the kidney biopsy. And then in stage 3, you can have a lot of tubular inflammation and cytopathic change, with significant interstitial fibrosis as well, which may affect more than 50% of the core tissue. So stage 3, you've got chronic established fibrosis affecting at least 50% of the cortex, as well as perhaps having more acute inflammation as well, with cytopathic change. So these are the classic viral inclusion bodies that you see in the tubular epithelial cells. Sorry, typo there. And you can see where the arrows are marked, so they're very sort of suggestive of viral infection. And if you stain for SV40, you can see the biopsy is loaded with BK virus. So this, if you like, summarises the histological features that I sort of described verbally a few seconds ago. Stage A, or class 1, or stage 1, you've got very minimal changes on light microscopy. Stage 2, you're going to have active inflammation and tubulitis, and stage 3, you have extensive sort of fibrosis and atrophy. And of course, it's very difficult then to differentiate from rejection, and you may have both coexistent BK nephropathy and rejection. Some people have suggested that coding for MHC proteins may help differentiate rejection from BK nephropathy. So this was a study that looked at the resolution of BK nephropathy, and it was a study that involved surveillance biopsies of 35 patients with BK viremia who were treated with immunosuppression, reduction. And what they found was that even when the viremia resolved, you had ongoing inflammation, and intraepithelial lymphocytes were seen on the biopsy specimens, even when the inflammation was even when the viremia had resolved. So what you've got here, you can't really see very clearly here, but what you've got in panels A and B, you can see intraepithelial, you can see sort of inclusion bodies here. Panel C, you've got an interstitial infiltrate with plasma cells. Panel D, you can see tubulitis, that's where the arrow is marked. And then panels E and F, you've cleared the virus at this stage, so there's no viremia, but you can still see active inflammation and still lots of lymphocytes within the epithelial cells. So, unsurprisingly, as the severity of polyomavirus nephropathy increases, the risk of graft loss increases to perhaps higher than 80% in stage C, whereas stages B, intermediate, and stage A, it's got a very good prognosis. And what are the risk factors for BK nephropathy? Well, these are the risk factors. The risk factors are related to the donor, so obviously the BK, if you have a BK virus seropositive donor, degree of HLA mismatching seems to be important. More common in men, more common in non-African Americans, diabetics, and men, and older age patients. And obviously then there are transplant risk factors, so acute rejection, cold ischemia time, delayed graft function, obviously the immunosuppressive load that you give, so the combination of tacrolimus and MMF seems to be a particularly bad combination. ATG, again, heavy immunosuppression increases viral replication, and there is a suggestion that the urethral stent as well may be associated with the development of BK nephropathy. So let's look at some of the data around steroids. This was early data looking which is a single centre study looking at 78 kidney transplant patients, and if you look at the risk factors for BK viremia and for established nephropathy, steroids and acute rejection were significantly associated with the two, presumably because a steroid pulse again encourages viral replication. This study collected data from the National Scientific Registry of Renal Transplants to look at the risk factors for patients who were risk factors for graft failure, patients with BK nephropathy, and looked at their associations with acute rejection, and certainly people with established BK nephropathy were also at higher risk of acute rejection. So if you had BK viremia, had treatment for BK viremia, you're also associated with acute rejection. Now, whether that's due to the reduction in immunosuppression that's causing that, whether it's an effect of the virus itself increasing the risk of rejection, isn't clear. So, which of the calcineurin inhibitors is more harmful? Well, it seems that tacrolimus is more harmful, and certainly more in the context of BK nephropathy, is more likely to be associated with BK. So, if you look at this data, this is analysis of the DIRECT study, which is a study comparing cyclosporin to tacrolimus in transplant patients who also got MMF steroids and basiliximab. And what you find here is that BK viremia is much more common amongst patients with transplantation who've been transplanted and are on tacrolimus, and similarly high-level BK viremia is more common in the tacrolimus group. And there seems to be sort of dynamic risk factors. So your steroid dose at 3 months seems to be important. The combination of tacrolimus and mycophenolate at 6 months seems to be important, and male age at month 12 and tacrolimus and mycophenolate at month 12 also seem to be important. So the risk factors seem to change according to time, but basically immunosuppressive load and combination of tacrolimus and mycophenolate acid appear to be important. Sorry about that. So what about alemtuzumab or Campath? This is a single centre study from Ohio in the States, which looked at the impact of alemtuzumab on BK viuria, viremia, and established nephropathy. And in this single centre study with multivariate analysis, they found there was no impact of alemtuzumab on established BK nephropathy. So how do we diagnose BK polyoma virus nephropathy and BK viuria and viremia? Well, first of all, you can screen for the BK virus, and you can screen in the blood or the urine. Screening in the blood is usually done by doing RT-PCR for the virus itself, and that's pretty sensitive and can detect the virus pretty well. The positive predictive value for BK viremia predicting established BK nephropathy is only 50%, but its real value is its negative predictive value, which is 100%. So if you have BK viremia, you've got a 1 in 2 chance of having actual BK nephropathy, but if you have a negative BK PCR, then you're not going to have BK nephropathy. And that's quite useful, because what that tells you is that a negative blood test excludes BK nephropathy, but a positive blood test doesn't necessarily mean you have BK nephropathy. You can also look in the urine, so you can just directly look at urine for decoy cells, and I'll show you some of those in a second, but they're basically tubular epithelial cells that have been infected with BK virus and shed into the urine, and they're obviously their use is very operator dependent and may not be particularly sensitive for actual biopsy proven BK nephropathy. You can do EM and look for Haufen, which is sort of aggregates of polyoma virus and tan-horseful protein, and these may be highly specific, but obviously the number of studies that have been done have been quite small, and it's going to be extremely operator dependent. Most centres will simply do PCR for BK viral load, and certainly if the higher the viral load in the urine, more than 10 to 4 copies, then you're much more likely to have viremia. And there's increasing interest in PCR for viral capsid protein VP1, which may predict actual BK nephropathy, but that data is predominantly experimental at the moment. And this table just summarises what I've just said, really, in terms of looking at screening tests in the urine. There's a real value in negative screening tests, but the positive predictive value of looking for BK in the blood or urine is pretty variable, really. So that is why most people would argue that even if you have BK viremia, you should go on and do a biopsy, because the positive predictive value of BK viremias are only around 50 to 60%. These are decoy cells in the urine, so these are cells that have been infected, tubular epithelial cells shed in the urine that have been infected with BK virus. What about the relationship between BK viuria and viremia? This was a paediatric study just looking at patients and looking at the association between viuria and viremia. And what you can see is that you'll have a high prevalence of viuria, as I already said. 64% of patients had viremia, but only about a third of those actually had established viremia. So there is a considerable drop-off between having viuria and then having viremia and then having established nephropathy. So how are we going to manage? Management really revolves around preemptive surveillance and treatment. So this was an interesting study that was a randomised controlled trial. Well, it wasn't a randomised controlled trial, but it was a randomised study that was really that's purpose was to determine the incidence of BK viuria, viremia, and nephropathy with tacrolimus and cyclosporin, and also look at the impact of determine the impact of immunosuppression reduction on subsequent viremia and develop nephropathy. So patients were randomised to either tacrolimus or cyclosporin. They had regular screening of BK virus in their blood and urine, and it was one of the interesting findings at the time was that viuria was highest in those on the combination of tacrolimus and mycophenolate. That's here, that's this purple line here, and viuria of more than 95 or 10 copies was associated with a high risk of viremia. Once viremia was detected, the protocol was to discontinue the azotherapy, the antimetabolites, so that was either azathioprine or mycophenolate, and if they're still viremic at 4 weeks, was then to reduce the calcineurin inhibitor. And using that protocol, you've got 95% clearance of viremia. So reducing immunosuppression appears to increase the risk of viremia and therefore reduce the risk of developing BK-associated nephropathy. And if you look at the outcomes, this is the sort of 5-year outcomes of that study that was published more recently. In the blue here you can see those patients with no sustained viremia, and in the green you can see those patients with sustained viremia. So you can see that strategies appear to work, because if you cleared your virus, patient survival and graft survival was much higher. They incidentally looked at rejection rates. You obviously have to balance the risk of BK viremia against rejection rates, and the rejection rate, of course, was low in the tacrolimus versus the cyclosporin group, but the graft survival and 5-year patient survival was slightly higher in the tacrolimus group at 91% versus 84%. So strong argument there in terms of managing in terms of management for reduce the screening with urine and blood, and then making reductions in immunosuppression. What can you do other than reducing immunosuppression? Are there any other drugs that you can use? Well, all these have been tried: leflunomide, cidofovir, IVIG, quinolones, interferon, all based on very small case series reports and small observational data. So I'll show you some of that data now. So some data from this single centre experience, from the single centre in the States, looking at the effect of leflunomide, sorry, spelled badly there, leflunomide on BK nephropathy. So these are patients who have established BK nephropathy. Mycophenolate was stopped, they were kept on low dose tacrolimus, and then started on leflunomide, and you got a reduction in BK load in both blood and urine. And more recently, there has been a randomised controlled trial looking at quinolones. So quinolones in vitro have some activity against BK virus, and so this very small randomised controlled trial, 39 patients with established BK viremia, were randomised to levofloxacin or placebo for 30 days. There was a reduction in immunosuppression, but that was as per local practice, so that varied from site to site. So big limitations in this study: small trial, variable reductions in immunosuppression. But as far as we can tell, on the basis of this, albeit limited evidence, there was no impact of levofloxacin on BK viral load. So in this review, if you look at all the study, the systematic review of the treatment of polyoma viruses, the authors conclude that there was really little benefit in adding cidofovir leflunomide in addition to reducing immunosuppression. So we just don't know whether there's any role for these drugs at the moment. And this slide again just summarises all the studies looking at different treatment strategies, and you can see in terms of immunosuppression rejection, there's pretty good evidence. Again, predominantly observational evidence, but reasonable observational evidence. Numbers are all small. When it comes to leflunomide and cidofovir, we really don't know whether there's any role for them at all. So just to summarise what the American Society of Transplantation say as to how we should manage polyoma virus, well, we should screen. They're recommending that we should screen every 1 to 3 months, or if there's allograft dysfunction or allograft biopsy. I think the role of regular screening is unclear, but certainly the role of looking for BK in patients who have BK in the urine in patients who have allograft dysfunction is very sensible, and you can look for it in the urine using EM, using urine cytology. If you've got somebody, you can identify decoy cells, but most people look at BK load, so do PCR in the urine. If the urine is positive, you then look for it in the blood. If the blood is negative, then you're pretty sure they haven't got BK virus. If the blood is positive, you can either do a kidney biopsy and confirm that diagnosis of polyoma virus-associated nephropathy and reduce immunosuppression, or some people will just say, well, if you've got BK viremia, that is a sign in itself of over immunosuppression, and you should reduce immunosuppression anyway. So you can make a presumptive diagnosis of BK nephropathy and reduce immunosuppression that way. Then you monitor the response, and hopefully you will have resolution in BK viral load, so you'll have clearing of the viremia within anywhere between sort of 2 months, longer up to sort of 6 months, that's it really. So occasionally you'll have some patients who will persist with low-level BK viremia, but most respond. Maybe a role for adjunctive treatment, but the mainstay is going to be to reduce or stop the antiproliferative drug, that's azathioprine or mycophenolate, and then reduce the calcineurin inhibitor dosage. So just to conclude, polyoma virus-associated nephropathy is a really important cause of graft dysfunction and loss. Surveillance of viral load in the urine and blood with preemptive reduction of immunosuppression is really the cornerstone of management, and the evidence base for other interventions beyond immunosuppression reduction is poor. I'll correct that spelling for immunosuppression, and with that I'll say thank you very much for your attention.